and welcome to our first in the Haematology Health Psychology online webinar talk series. Today we are presenting the welfare webinar. We have special and very hopefully well-known guest with us today, Daniel, and a panel with us as well, so I'll let everyone introduce themselves.
Hello, this is Daniel. I am the welfare support advisor for the area. Oh, there's the pictures on the screen. Yeah, I'm the guy in the middle, and I literally do the welfare support advisor side of things for the area. Yeah.
Hi.
So that's my.
Hi, I'm Emma. I'm one of the psychologists in the team. I run the virtual support group and a few other different things in the department.
Hi, I'm Sickle. I'm the assistant psychologist in the health psychology team. So I work with Emma and Rosella.
And I am Rosella. I'm one of the psychologists within the haematology team. Rachel Keziadu, the consultant haematologist, is going to be joining us shortly, so we will get her to introduce herself when she can.
So Daniel, what's your role? What do you going to tell us a bit about what you help with and why people might want to contact you?
Right. So my role, literally, I do a lot of different things. One of the things I do the most happens to be applications with personal independence payment.
Most people know that as PIP, right?
Yeah, most people just know it as PIP. Funny, some people will call me up and say, I want to apply for PPI. And I said, no, it's not PPI. It's PIP. So yeah, that's one of the things I do a lot. And this is for young adults from 16 years upwards. And for younger people, those below the age of 16, I can assist with things like disability living allowance. But obviously that is probably a lot harder to get, mostly because I have to rely on the parents to give me information about how the condition is affecting the child. So that can be quite difficult. Now, back to the PI, for those people who are not comfortable filling in forms, I would help them to do the actual write-up on the form itself before it gets posted off to Department for Work and Pensions. And as part of the application process, they are required to attend an assessment, and I would also help try and prepare them for that. Another thing that I do a lot of is write support letters for housing. Now, as you know, with Sickle Cell, our patients do need to live in certain types of accommodation. For example, they really should live in a place where it's not damp, it's not moldy, and the heating is quite good. But somehow in London and probably across the whole country, housing is a bit of a problem. And so these issues do come up a lot. And so, yeah, I try to advocate for them, write letters to local authorities or private landlords to try and get them to understand that with Sickle, we really cannot have our patients to live under those conditions, because otherwise it means repeated visits to hospital as a result of, crisis being triggered too often. I do write quite a fair bit of letters also to employers, but I would only do that when somebody asks. Maybe they're working in an environment. So, for example, if somebody's working in an environment where they are required to do shift work, and as you know, nights can be a lot colder than the daytime, and so our patient might say that I need a letter to give to my employer to explain about the condition and why it is not quite appropriate for me to do a night shift. Yeah, I will write things like that. I would also get involved in things like students who are applying for something called disabled student allowance. This is again a bit of benefit that's available for them to access. And literally to try and help them remain in education, to go through this education and to qualify properly, because as you know, with sickle, it's not any kind of job, every job out there that they can do. So we want to try and encourage them to, at the very least, give themselves a chance by studying the right things. So yeah, the disabled student allowance comes in handy. And believe it or not, I've kind of, I'm a bit of a motivator. I've kind of motivated so many people to, have a bit of confidence in themselves and go back to uni and do something amazing in their lives. So yeah, it's something I actually enjoy more than anything. If I'm able to, motivate someone to go and get the best out of themselves. Yeah.
That sounds great, Daniel.
Yeah, cheers.
How long have you done your job for? You've been in it a while.
How long? I've been with the team now just a little over 5.5 years. So I started, I think, October 2014 it was. Yeah.
It sounds like you really enjoy it. Like there's lots of bits of your job that you find really interesting.
It is an interesting job in the sense that previously I did do welfare work, but this was for a government department. And in all that time, my role was all about trying to find the weakest, the most disabled people out there, the people who just don't understand the welfare system, and help them hold their hands and get them to do it the right way. So when I came to with the Sickle team, I wanted to do exactly the same thing, but I had to learn about Sickle to begin with. Man, that was something. I call it baptism of fire. Yeah, working on the job, and my goodness me, Sickle. So anyway, Sickle. Why do I think I enjoy it? Behind every diagnosis, there's a real human being there who is struggling with pretty much everything. Wake up in the morning, they're already tired. And so for those of us who have the opportunity to try and put something back into their lives, I will do that. So I think for me, being able to put that little smile on somebody's face, because maybe we've applied for PIP and it went through, maybe we managed to get them out of a poor housing situation. Maybe, a child needs something, and we managed to get them some grant from a charity somewhere to get that child that toy or whatever it might be. So to just put a little bit of smile on somebody's face, I suppose, is what it is that make me enjoy what I do. Yeah.
Great. I think we're now going to move on, are we, to one of the more specific topics and go through some questions about that, are we?
Okay.
So as part of the series, we asked lots of different people some questions and topics, and we've sectioned that out into themes. That is part of the feedback at the end of this talk. If you want to give us any kind of suggestions or ideas of things that you'd like to hear about in the future, both from Daniel or from the psychology or medical team at Guy's, please do fill out our feedback questionnaire that we'll be giving at the end via link, and then we'll be able to do that for you. So these are just some of the topics and some of the questions that have come up so far. So one of the first ones is thinking about housing. There's lots to say about housing.
Yeah.
Where do you start, Daniel?
Well, I mean, housing, I touched on a little bit of that. Housing is a bit of a nightmare situation to solve, to be quite honest. And I think it's mostly because across the whole country, there's a housing shortage. So housing, this is not a problem that we are able to solve overnight. It would involve a lot of letter writing to housing departments. There has been situations where we would actually escalate this thing, the problem, to the local MP and the director of housing even. So, and it might be something just very, very simple. It might just be a case that the housing is overcrowded. There's too many people in the home. So the person living with sickle cell doesn't really have enough space to recover from when they have crisis and so on. And this is a very, very simple situation to solve. But first of all, the local authorities need to accept that there is this problem that they need to take seriously, and that is the hardest thing to do. It's not easy for them to accept that there is a housing need. So yeah, it's a big fight. It's a big fight. So everybody who comes to me, usually with housing related issue, I mean, the first thing I say to them is that, look, this is going to be a long, 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 hard fight. And they have to consider getting their local MP involved right from start. They have to consider basically writing lots and lots of emails and copy pretty much everybody in, including the director of housing, because, ultimately, when the people in charge of these policy about housing are not aware of the problems that their policies are creating, then I don't think we're going to really solve these problems. So yeah, housing is a big problem. And in the sickle, well, in particular, it's usually a case that maybe there's quite a fair bit of mold. It could be anywhere in the house. And so with sickle, when somebody's exposed to that level of mold, you're going to find that they are sick a lot. The hospital attendance is pretty high. I have some pictures. Maybe at a future day when we do another one of this, I'll pull out some pictures to show on a slide where, the living conditions were just really, really, really bad. And we struggled to get this person out of this accommodation. I think this person still lives in that accommodation right now as we speak. So it is hard. So I suppose for us to solve housing problems, it's going to take a fair bit of advocacy at the level that probably beyond us. Maybe this is where I think the society maybe needs to come in and start to tackle these problems at the level where, when we write these support letters to housing departments, we're not constantly having to answer this question: what is sickle cell? Why do they need a specific type of housing? If we can get this advocacy done at that level, then maybe we'll solve a lot of the problems for us. I don't think that comes up a lot with housing, is that people generally, when they get to a certain age, they don't really want to be in mom and dad's house anymore and sleep in the couch anymore. And so the question then is, how do we make a case that this person can go on the housing register? And that is also quite tricky. Some of the things that we've had to do is to literally say to mom and dad, look, you're going to have to kick your child out. Force them to be homeless. It's the best, but sadly, that's what it is. Because if there's no evidence that you're homeless, then the housing department is just going to say, well, actually, you have a home you live in, so what is the problem?
Samuel, can I ask?
Say again?
Can I ask you something?
Yeah.
One of them, I've heard different things about people, whether they're allowed to move in this pandemic or not. Whether does it depend on the council, or what is it that lets people move or not?
I think the official guidance is that from around the middle of May or so, people can move as long as everybody involved can guarantee some kind of safety. Yeah, it's all down to the safety element and whether you should move or not. But I suspect, I don't have any evidence for this, but I suspect most local authorities will probably try to discourage that. I have spoken to somebody, I think 2 weeks or so ago, who needed to move, and regardless of how many phone calls we made, they were simply just told, look, you're going to need to wait till this COVID situation is a bit more stable. So yeah, in answer to your question, people can move as long as the safety side of things can be not necessarily guaranteed, but can be taken care of to an extent where, nobody's been exposed to what we can't see. In other words, I don't know if that answers the question.
No, it's helpful. I think it depends a bit, from what I've heard, it depends which council you're under.
Yeah. So, I mean, generally, nobody really wants to take unnecessary risks at the moment. I think that is the basic issue. So, local authorities, if they can avoid exposing people to something they can't see, then I like to think that they will prefer to do that. So yes, in as much as the most can be done, I think that everybody's just being cautious, really, to be honest.
And that's what's understandable at the moment in terms of thinking about the situation, as you mentioned, COVID-19, and people have had to be shielding and in their houses, and that might, for some people, highlight some of the challenges at the moment with their housing situation. So something that might feel more manageable when you're able to go out a bit more. Whereas at the moment, some of the difficulties within housing and the housing conditions, as you mentioned, things like mold, would feel significantly worse at the moment while people are shielding. But also, I want to pick up on a few of your points that you mentioned about generally the society challenge with housing at the moment, that there is limited housing available, and that makes it more challenging for young people who want to make that move from parent home to living on their own, but also in terms of the different houses that people can move to. You mentioned writing support letters would be helpful and talking people through the process. Could you tell us a little bit more about the specific support you offer to guide people through the housing process?
Well, the first thing I try to get them to understand, of course, is the shortage. So therefore, it's not something that is going to be fixed overnight. It could be something that will go for many, many, many years, in fact, because it just depends on where, even in those situations where the local authority accepts that, yes, there's a housing need, and yes, this person can go on a housing register, they have tiers, so to speak, levels where they can put you. So if you happen to be in the bottom of the ladder, then you could be on that register for 5 years, 10 years, and forever even. So that is something that people need to bear in mind. But I mean, in terms of the support that we give, we literally try and highlight in our letters why this person needs a specific kind of accommodation, and why, if they don't get that, then what happens. So when we highlight things like the mold, the cold, the damp, we also explain in our letter that, well, if those situations exist in the building, chances are this person is going to be sick a lot. Chances are they're going to have a lot of chest crisis. Chances are the hospital is actually going to end up being their home, because the frequency of them being ill is much, much, much higher. And we also highlight the fact that overcrowding doesn't necessarily help the situation, in the sense that when this person is ill, a lot of the time they just need a quiet place to just basically keep their head down, keep up with their fluids and medication, and just get well. But when there's nowhere for them to just disappear to within the home to have that peace and quiet, the sickness actually gets worse. So housing is a bit of a tricky one that I think, frankly, we're going to need to get a proper housing expert on one of the, if we're going to do this on a regular basis, we can get a proper housing expert to give us some really good legal advice on this one, because this is where the whole thing begins to fall apart, because local authorities, knowing full well that everybody who comes to them doesn't actually know the housing legislation, how long they need to be in the area, what exactly constitutes the responsibility that they have to take care of. So I think we probably need a proper legal advice on this. But for the moment, we try to support the best we can with the support letters, and literally just keep pushing the housing officers until they had enough of our letters and solve the problem.
And do you sometimes support people with grants and things? If they can't get a washing machine or things that can do with their houses, that sort of thing. Do you kind of have a list of ones that people can apply for, and do you kind of you're on the inside track on some of those things.
Yeah, there are a lot of grant-giving charities out there. A very good website, in fact, to look at for charities that give grants is this website, this organization called 10 to Us.
Right.
Yeah, 10 to Us is a really good place to go for charities that give grants. You know, there are hundreds of them with different things that they will fund and different qualifying conditions, of course. So because there are so many of them, usually when somebody comes to me and say, I want XYZ, I try to get them to do a bit of work themselves. And listen, go find the charity. That's me cheating, of course. I say, look, find the charity. Let's figure out what the qualified conditions are, and then let's write to them accordingly. But usually myself, I there's 2 or 3 that I know they tend to come through for us a fair bit, so that I tend to stick to those 2 or 3. If anybody needs something a little bit extra than that, then that's when they have to do some of legwork themselves and bring me the content and the conditions that attach to that grant, and I write the letters. And then we do the application together. Yeah, so people can get help to get things like fridge, cookers, any household essentials that they literally need, you know, in order to be able to carry on living where they are. Yeah, and funny enough, that same website, there is a benefits calculator, and I think this is a really, really good tool. But there are times when somebody comes to you and the areas are a bit blurred. You're not quite sure off the top of your head what you can help them to apply for. So I use these calculators, and it will just ask series of questions, and we have to put correct information. Of course, it won't be sort of imaginary figures. It will have to be the real figures. And so by the time we get to the end of that calculation, it will point us in the right direction, what to apply for, where to go to apply for it, and how to literally get that benefit in the person's pocket. So yeah, there are these tools out there. Yeah. Does that help?
Sounds really helpful. Thank you.
Okay. Yeah.
Definitely. And I'm also thinking about what you said about housing experts. So I think that's a really good idea, thinking about a future series. There's so much that you've just talked about with housing today, whether it would be helpful in the future to do a specific mini series perhaps on just housing, to be able to talk through, for example, things like the different types of housing that might be available. You've talked about local authorities, you've talked about private. We know that there's also temporary accommodation as well. So that sounds like a great idea. And again, if you think that will be something, listeners, that you think would be useful, please let us know in the feedback, and that's something that we can arrange. Shall we move on to another topic?
Yeah, sure.
So a big one that we know that often comes up for people is thinking about access to welfare support. And you already mentioned personal independent payments, or PIP, as a lot of people know it. Could you give us an overview around what types of support are currently available for people with a diagnosis of sickle cell?
Well, the answer is simply none, zero. But you have to apply for things, which is where I suppose the PIP comes in. So a lot of people make this mistake and think that the diagnosis itself gets them the entitlement or gets them the benefit. You know, this is where the first mistake starts, when people are applying for things, because that the diagnosis itself is totally irrelevant to what people can get. Now, in terms of applying for personal independence payment, what people again need to understand is that it's a numbers game. It's all about numbers. So this PIP, personal independence payment, was introduced, I think, back in 2013 to replace disability living allowance for 81 over the age of 16, between 16 to 64. Now, for those sickle patients who are already on disability living allowance, or let's just call it DLA, they all are going to need to get moved over onto PIP. So the first mistake, don't even think of sickle as something that guarantees you any benefit. The second thing is that when you are on DLA and you are being moved over to PIP, don't take it for granted that having been on DLA, it will be a smooth transition to PIP. It will not happen at all. I said earlier that PIP is a numbers game, so everything going on with a sickle cell patient, they have to be able to explain that in such a way that it triggers points as they are getting assessed. Yeah. So the first thing that happens with PIP is that you've got to make a phone call to Department for Work and Pensions, and then during that phone call, a few questions will be asked. You answer that, form gets sent to you. Now that form, if you remember earlier, I said that I help our patient groups to fill in the forms if they need that help. The form is the bit where I tend to get involved from. I will help to fill in the form. For those who are comfortable to fill in forms themselves, literally what I tend to do is to explain to them that there's this thing called descriptors, or the point system, what it means and how they need to be thinking about the answers they give on the form, how they are phrasing, the choice of words they are using on the form, and how that will be seen by the decision makers. So those who can fill in the form themselves, I literally do that with them so they can go off and hopefully fill in the form correctly. So basically, once the form is completed and it goes off to DWP, they would then send that information to the private contractors that do assessments for the department. Now, this is where things become very, very tricky. Why do I say tricky? Okay, sickle cell is one of those conditions that you can see somebody walking down the road, bigger muscles, bigger than my legs, and then this person tells you, man, I have a lot of pain. And you're going to be like, what? Yeah, so it's very, very difficult to, first of all, believe that this able-bodied, fit person that's standing in front of you could be going through this experience. Yeah. So it's very difficult to believe that.
So we definitely know from our experience there's huge psychological and physical implications, isn't there, of sickle cell? And that from day to day it can change so much that sometimes people can feel really well and sometimes they can feel not so great.
So it is these fluctuations in sickle that makes it very difficult to make a case for any support, So sometimes when the doctors, this is where you guys come in to try and shape this for us a little bit. When the doctors write the support letters, of course, the clinicians, doctors are generally very optimistic people, and they use, optimistic language. And so when the decision makers see phrases like sickle cell causes pain, and that pain is called crisis, and that pain is intermittent, they latch onto that. Yeah, how intermittent is this thing? So how often is the sickle patient getting these crises? How often are they getting admitted to hospital with crises? Yeah. So what we find is that even with the patient group themselves, when they're explaining how the sickle affects their everyday activity, when they themselves talk a little bit too much about the crisis or this intermittency of this pain, then they're not really doing themselves any favors. Yeah. What they should really be talking about is the constant daily pain and discomfort that they get from sickle. This is what they really need to be talking about. Somebody might say, "Oh, talk about a worst bad day, their very worst day," to focus on that, But for me, what is a worst day? What is a bad day? I've met a lot of sickle patients who will say to me, "Daniel, I wake up in the morning, I have to take dihydrocodeine on oral morph to even manage to get out of bed." And then they say to me, "That's a good day." And I say to them, "Well, actually, if you had to take something this strong, oral morph and dihydrocodeine before you get out of bed, I don't think you should think of that as a good day." So how they phrase what they're saying to the assessors on the form itself, and at the assessment stage, this is the key. This is what literally would trigger the points. Okay, so a typical example might be, somebody who just taken the hydrocodone or more before they got up in the morning. Now they're feeling good about themselves, and that's fine. Now this person needs to go and cook their food. Maybe they can manage that. So when an assessor asks them, "Can you cook?" Yes, they're going to say, "Yeah, I can cook," but when I'm having pain, and I cannot cook. What they haven't said is how often are they having this pain? They are having the pain every day. This is why they're taking the morphine or the oral morphine with dihydrocodone. But they haven't explained that. Yeah, they haven't explained that. We know that they have a lot of pain and discomfort in their joints all the time. Well, majority of the time. So if somebody's having pain in their lower back, their hips, their knees, and I understand they do get a lot of pain inside the bones in the legs, they are going to struggle to stand in the kitchen, to cook. But they haven't explained any of that to the assessor. They just said, "I can cook, but when I'm in pain, then I cannot." The only thing the assessors had, sadly, is that they said they could cook. So they're not going to score any point on this. But if they change their strategy a little bit and explain the actual difficulty they have, then perhaps they have a chance. Yeah, and this is what I try to explain to people when they are applying for any kind of support, especially personal independence payment. Yeah, and you're going to ask something.
It sounds like you're saying that it would be really helpful to be explicit about what people are experiencing every day, so to really make clear what their experiences are on that worst day, as you said.
Yeah.
And that is a change of mindset for people, I think, in terms of people trying to get on with things and people trying to, as they should in many ways, they're trying to strive to stay well and trying to keep themselves well. And it's a change of headspace in terms of having to fill out a form where you think about your worst experiences, and that can be a challenge for people to be able to think about, to be able to acknowledge sometimes that those days are really bad. But that's the whole point in needing support and getting support, that this is money that could help people to live better lives and better quality lives. And it sounds like you take them through the process of supporting them through that. And from both what I'm hearing is the application process itself and helping them to fill out the form, asking them questions around what they need to put on the form. And then also I know that you also help with things like the appeals process if it doesn't always go to plan the first time.
Yeah. So you're right. Everything you just said there is correct. Absolutely. So, but we do all that, but we still have problems. Again, for the reason that with sickle, because it's not a disability that's visible to these assessors, they, somebody can explain all of this to them, and they will still not score allocating points to the activities at all. And so when that happens, there's two things we can do. The first stage is something called mandatory reconsideration. So that's effectively us saying to DWP that they got it wrong and they need to reconsider the decision. Now, usually it's helpful if we can find some additional information, perhaps from the hospital system or from their GP, to then allow us to get this mandatory reconsideration through. Now, sometimes it becomes a question of word games, in as much as it probably sounds wrong to put it that way, but that's sometimes what it is. How the decision makers choose to phrase the reasons why they didn't award somebody. Now, we would sit down and look at this reasoning behind the decision and try and kind of break into little pieces and see where we find the gaps, the inconsistencies. A lot of the time, by the time we do it, we find that actually it's all because they just don't know anything about sickle cell. So they're basically misinterpreting everything that they're being told. And so, sometimes we get lucky. We get lucky and we get the mandatory reconsideration through. Failing
Well, I
that,
don't know if that's luck. I wonder if that's actually hard work from everyone. It sounds like there's a lot of hard work that goes into this. So I don't know if that is luck. I'd maybe say
no,
that's hard work and an effort being put in,
yeah,
as well as a little bit of luck, maybe.
yeah. Well, you know, I'm just kind of trying to. Well, I suppose I'll just be a little bit. What's the word I'm looking for? Put it this way. Yesterday, for example, I've been working on this mandatory reconsideration. And it took me several days, and I finished it yesterday. You know, I wrote something like 11 pages, not just one mandatory reconsideration. And just me trying to find holes in the original decision that was made. So yeah, it can be quite a lot of persistence and just sheer hard work on the part of the patient and myself and everybody else we can find within the health system who can give us supporting evidence to back up our side of the argument. And the reason I say when we get lucky, I use that because we find that 90% of the time they're going to stick with their gun and say they got it right. So these 90% of the time when they say they've got it right, we know that we have one last card to play, which is when we have to take the whole thing to the tribunal. Now, where I think is really important to try and load up the application right from the beginning with evidence, and good solid explanation is that at the appeal where we have a doctor, there's a judge, and there's going to be somebody who's supposed to be a disability advocate, they would all look at the evidence in front of them. And if the evidence was already there anyway, but DWP still got it wrong, then we have a very, very good chance to win. Yeah, so that's what I love to load this up with so much explanation and evidence right from the beginning. Yeah. So yeah, we are winning. We are winning a lot of them. The last few months, I don't remember any that we've lost. We are winning literally all of them. So yeah, people just have to not give up on the first stage. Yeah, because naturally, that's what I suspect. This is what the decision makers are hoping that you'll back off. But you don't back off, we're going to keep pushing this, and then we win. So we just need to encourage our folks to understand that, look, yes, it's tough. Sometimes it can take up to about a whole year by the time we get to the appeal stage. But when the win comes in, the EWP will have to pay everything they've denied you for a whole year. So, yeah, don't give up. You have to just keep pushing.
So what you're saying in that is that once people do win the PIP process or application or appeal, that money then gets backdated to when they first applied? Yes,
absolutely. From the first moment they made that phone call, the money will get paid back to that point. And this is what it is. It's a long, hard fight. Although we don't get to this sort of stage very often, I think because of how we approach the whole application process, the people that I work with, the ones who, understand that, like you said, it's a whole mindset change thing. They really have to approach this application from a totally different perspective to what perhaps they used to. And so those who do it very well, we are able to get the PIP in before we start worrying about mandatory reconsiderations and appeals. So most of the applications we do, in fact, we do get them in. And so we don't have to do the appeals, no. It's very satisfying, I have to say, that we are able to do this consistently. Yeah.
I'm wondering a little bit about the letters. And I know that you write letters of support, and I'm aware that the medical team writes letters as well. Is Rachel with us now?
Yes, I am.
Rachel, do you want to introduce yourself, please?
Apologies, no one can see my face. My camera is not working. So my name is Rachel Casiedo. I'm one of the Sickle Cell consultants at Guys and St. Thomas's Hospital. been here for a few too many years, I suspect.
Yeah.
So we're just talking about the welfare support and PIP process, and I know that the medical team often writes supporting letters to help people in this process. What do you tend to write or offer in the letters?
So we have a standard letter that pretty much describes sickle cell and tries to explain the unpredictable and completely intermittent nature of it, hoping to help the assessor understand that who you see in front of you today is not necessarily who this person is going to be a week or a month down the line. But additional to that, we individualize it to the patient. So it's a reflection of your particular problems as we understand them. So, for example, people who have chronic hip damage and can't, walk very far, or we know are in pain or are pending surgery, we will put that sort of information on with their permission, obviously.
Mm.
Yeah.
That sounds really helpful.
Yeah, absolutely. And I think that's the thing, because the letters, we can't really leave them as just a generic. So like Rachel said, we definitely have to personalize them and pull into it everything that's going on with the patient. Yeah, definitely. I know what you probably don't do, or maybe not want to do, is to say how, in your view, that these conditions or the various things happening with this patient could potentially affect how they approach daily activities. Is that an area you tend to touch on as well, if Rachel?
So sorry, Daniel, I didn't quite understand that. What do you mean?
Yeah. No, I was asking, when you personalize in the letters, so to speak, do you touch on the fact that if we think about everything going on with the patient, perhaps it would affect the way they approach daily activities, the way they go about doing daily activities, how it becomes a bit more difficult for them because of all the health conditions they have? And just wondering, is that something you would normally do as a matter of course, or unless somebody specifically asks you to factor those in?
Yeah, so as you can imagine, the number of letters we write is not inextensive. So for some people, a generic letter suffices for their needs. But for those who need higher support, then usually when someone's going through an appeal, we would usually have a conversation to try and get a better understanding of what their limitations are at home. Obviously, we can only comment on the stuff that we are able to assess.
Yeah.
So I will know what someone's walking distance is from their hip pain, because we've documented it in previous letters and previous consults, and then we might have a conversation about what does that translate to at home. Does that mean in the morning, for example, you can go and make your tea and then have to take a break, or have a shower and have to take a break, or can you get to the shops, can you not get to the shops? So we will then have a bit more of an in-depth conversation to have an understanding of what bits are important to the individual, and then make sure the letters reflect it.
Okay, that's good. Yeah, sometimes what I've asked patients to do when we're applying for the paper and we're trying to find the evidence is, I tend to ask them if they have letters from the hospital. Sometimes when they come to you and you will send them letters to sort of give them an update on where they are in terms of their health. I would tend to ask for letters like that to try and pinpoint things in the diagnosis that I can try and interpret in a certain way. Because I have a bit of a luxury in terms of me trying to extract that information of their letter and trying to put that in benefit kind of language, without worrying so much about maybe how that might be seen. Because I tend to look at the holistic approach in terms of what the diagnosis is, what that might actually mean to them on a day-to-day basis, and so on. So, yeah, it is definitely helpful when we have the letters, and then we can sort of work off the letters to help support the application process. Definitely.
One of the questions that came up from a patient to both you and Rachel is the idea that when you have more medications, it means that you are more unwell, and that might mean that you get more access to welfare support or any kind of benefits. Rachel, what's your kind of thoughts on that in terms of if people are taking more medications, does that mean that they're more unwell?
I sort of understand the logic of that, and in general terms, I guess so, because if you're well, you're not on any medications. If you're slightly unwell, you may be on one, and the more problems you accrue, the more medications you would be on. But it has to be tempered slightly, because if you think about someone who has probably the illness that terrifies most of us the most, like having a cancer, they may well be on just one medication, but it is not a measure of how unwell they are. So the number doesn't always translate into the degree of illness. But in broad terms, yes, someone who's on 6 medications is likely to have more medical problems than someone who's on one medication in broad terms.
Yeah.
And for then thinking about the forms, Daniel, does that translate in any way when you're thinking about the application process?
Yeah, yes and no. Yes, in the sense that what Rachel said is correct. No, in the sense that when they get to the assessment stage, now they're sitting in front of somebody who, majority of the time, they don't really know a great deal about sickle cell, and they haven't really bothered to research it that much. And as far as they're concerned, they have the patient sitting in front of them, and they're asking them about every single medication they are taking, not just pain, for any medication they are taking. Now, the sad part is that for the assessor, the fact that the patient is able to tell them, I take this, I take it for XYZ, I take this and I take it for XYZ. For them, that seems to suggest that this person is alert enough to understand what's going on with them, and therefore can take care of themselves, and therefore does not need as much help as we are trying to get for them, which I've always struggled to understand that thinking behind why the assessors do that. I mean, the only thing that I've always sort of arrive at when I think about why they do this is that maybe the pit was never really there to try and help people at all. Maybe it's just something they've introduced to take people off disability living allowance, knowing that PIP is a numbers game. And so it's very difficult for a lot of people to sort of explain their symptoms and how they're struggling on a daily basis in those numbers terms. So it is a bit of a heartbreaking one. And if you think about sickle patients also, these guys, they are expert patients. They know everything. They can combine it whichever way to deal with any situation they face every day. So it kind of discounts them almost immediately just because they understand their condition this well and know what they should take to deal with different situations.
They're definitely expert patients. But it's good to hear that you are supporting them through the process. And I'm sure there's lots of questions that people will have. And as part of your feedback forms, if you've got any questions that you want to add, and if you want to watch a PIP specific series, and that's something that we can do for you as well. I wonder if it might be useful for us to move on to thinking about our next topic, which is around medical care and prescriptions. One of the big questions that lots of people have had is partly around COVID, but also lots of the changes in how medical care is being given, and also prescriptions. So perhaps I'll start firstly with prescriptions. We know that people with a diagnosis of sickle cell at the moment have to pay for their prescriptions, and this is something that various groups have taken to Parliament to try and contest. And that's something that I know that the teams are working hard on creating some kind of equality, considering the amount of prescription medications that people need. big question is, how do I, is there any way of being exempt from prescription charges?
Well, sickle just happens to be one of those conditions that is not listed as one of those that should be exempted. However, I know that some of our patients, they've managed to get their doctors to sign this certificate, which then exempts them. So I think this is something that we need to encourage all of our patients to literally be on their. This is their GPs, by the way, not necessarily the hospital doctors, GPs. They just need to be on the GP's case until GP eventually agrees to sign this exemption form for them. So I know people have done it, and so therefore it can be done. But then obviously it's up to the individuals to take on this fight with their GP and make sure it's done. Now, in the absence of that, what they could also do to reduce the cost of the prescription medication is to subscribe to this annual thing where they pay £104. I know it still doesn't make sense that they have to pay, where other conditions not as bad as sickle and don't have to. But in the absence of getting the GP to agree to sign this form for them to exempt them, best thing, pay the 104 every year. It can be done on sort of a direct debit where they literally just take about £10 or so and 4 pence every 10 months throughout the year. And so that way it's just kind of rolling. You don't necessarily have to remember to do it because it's on direct debit. So, but, I would hope that at some point this pressure that is going through Parliament. I really hope it's a pressure. I'm not sure, but I really hope at some point, the government will see the need to literally put sickle on the list of medications that should get the exemption. I really, really hope so, because, when somebody's taking 10, 15 medications where, you're asking them to pay £9 something for each one of those is crazy. So meanwhile, I think two things we can encourage them to do: push the GPs and get them to sign that piece of paper to get the exemption through. Failing that, let's encourage all of them, especially the ones who definitely are not on any benefit that exempts them, to apply for this subscription thing where they only pay 104 for the whole year. But regardless of whatever is on the prescription, it could be 220 items, and they will literally have all covered on that one subscription, that prepayment thing. So
thanks for that, Daniel. I wonder, Rachel, if you've got anything to add into what Daniel said about prescription charges.
So as we can all see from events happening on the streets currently, change is made with a bit of agitation. There have been a number of campaigns to try and get free prescriptions for sickle patients, and the society was doing some work around this last year. And it really does need engagement from the patient body. It really, really does. So people I don't know if the Sickle Cell Society website still has the campaign going. They were looking to collect data on the effect of daily prescriptions on patients' lives. So I guess people need to keep their ear to the ground and try and agitate, because it was a priority about 5 years ago, and the society and the APPG were trying to drive this through. We were trying to get people to write to their MPs about it, and it sort of all stuttered a little bit with the elections happening. And if it's important and essential, I suspect it really is for a lot of people, we just need to agitate about it. We really do. But at the moment, the prepayment prescription is your best bet. We don't have any options we can offer you from the hospital to get your prescriptions for free. Although in terms of COVID, we are posting hydroxycarbamide and Exjade out to people for free at the moment.
I've heard that you can write to the prescription authority yourself and request extenuating circumstances. A few people in the support group have had success that way, so maybe might be something to look into.
Yeah, I think generally any of these things anybody can do. So for me, I write all kinds of letters. So if somebody came to me and said that I should work with them on a letter like this, I would definitely write them. But obviously,
it's difficult to prove exceptionality though. If you're a student receiving a grant, you probably won't be able to prove it. If you earn any version of an income, you probably won't be able to prove it. And actually, despite the fact that individuals can get the system to work for them, it's better if we just get the system to work for everyone. Sickle is an inherited condition, is not acquired. There's nothing about anyone's lifestyle that ends up with you having sickle. You're born with it. You should not have to pay for your prescriptions. A sickle patient who develops diabetes suddenly doesn't have to pay for any of their prescriptions, because diabetes, which is an acquired condition, entitles you to free prescriptions. Thyroid disease, acquired condition, entitles you to free prescriptions. I personally think this issue can be solved, but it just needs us all to talk from one sheet with one voice.
That sounds good. Thank you so much for putting in the information about that. Let's move on now to thinking about coming into hospital. At the moment with the COVID-19 virus, as we've been talking about, lots of people with a diagnosis of sickle cell have been shielding, and there have been some concerns about coming into hospital, how to get to hospital. So I wonder, Rachel, if you might be able to give us a brief overview of the process of coming into hospital and being in hospital. And this is very specific at the moment to the COVID-19 virus and the shielding recommendations that have been asked by the government of sickle cell patients to make sure that they're protected and kept safe.
Okay, so I will try and do this in a couple of sections. So first of all, shielding. Shielding advice is out there to keep our patients safe. Anyone with an underlying medical condition seems to be at extra risk from this virus, and it seems to have a disproportionate effect on Black and brown people as well. And obviously, most people with sickle belong to those ethnic groups. The idea of shielding is that you stay indoors, avoid the public, and don't come into contact with anyone who has the virus. Hence, you don't catch the virus and not run into any of the problems you see with it. And the sickle doctors across England, we think this advice has worked, because we certainly didn't see as many people in hospital with it as we had expected to see, given the numbers we saw in the early weeks. So shielding definitely works, and if you can comply with it, we think it's in your best health interest. What is happening in the hospital now, and certainly if you haven't been to the hospital for a while, it will feel a very different place when you do come in. But I should like to stress, a hospital is being made as safe as we possibly can. So if you need to come to the hospital, please come to the hospital. Every single sickle service in the country has evolved a contact system. So most sickle services, Monday to Friday, 9 to 5, there will be a phone number that you should be able to dial to speak to your team, to have a discussion about whatever your health concerns are. And if your team say, come to the hospital, please come to the hospital. It is safe for you to come to the hospital. Obviously, we're trying to make sure you don't come here necessarily. So we'll have the conversation, and if we think whatever the problem is can be managed at home in the community, we'll encourage you to do so. But if you need to be in the hospital, then absolutely, please come and you will feel safe. So the A&E department will feel different, because A&Es are now split into potential COVID areas and COVID-free areas. So if you have any symptoms that suggest that you may have COVID, like a fever or a cough, you'll be managed in the potential COVID areas. But this is done with both your risks being managed at the fore. So the staff that approach you will all be wearing masks. They'll be likely be wearing visors. We're all wearing scrubs in hospitals now, so none of us are wearing our normal clothes anymore. And they'll probably be wearing an apron. That dress code is no different if you're in a non-COVID area, but I guess you'll be a bit more sensitive to it in a COVID area. In A&E, the processes are exactly the same. You get your analgesia as you would have done before COVID. You will get admitted to wards just as you would have done before. But again, the change on the ward is everyone is wearing scrubs. So all the nurses are wearing scrubs, all the doctors are wearing scrubs, and all of us are wearing masks. And in clinical areas, we're wearing visors as well. Your management in the hospital is no different than it was before COVID. You get your investigations when you need them, you get your blood tests when you need them, you get your transfusion as and when you need them, and none of that is any different. at all. I don't know if that covered most things you're after there, Roselle.
I think that definitely has, and hopefully reassured some people around what they need to do if, as you said, they do need to come into hospital. I know that we've sent out some information about the changes that are going to be happening within clinics. So if anybody has any questions about that, please put it into the feedback form, or also look at the letter that's being sent out to you via email. If you haven't received one of these letters, please give us a call via the nurses WhatsApp group or via the HPS Health Psychology contact number or email. Thanks to Rachel for joining us for those sections. If we may well do a medical series with all of your consultants. So if that's something again that you would like in the future, then please let us know, and that's something that we can facilitate and send to you at home. Thinking about coming into hospital, there's been lots of questions and queries about ambulances and hospital transport and getting taxis. Daniel, are you aware of any resources or pots of money that are available to be able to support them in terms of coming into hospital, or any care when they are at home?
Well, a pot of money would be great, but I think with guys at the moment, what I know, I could be wrong, what I know is that especially with those who are on things like exchange transfusions, I believe the hospital sends the transport to collect them, and basically the whole process is done in a day. I think Rachel is still here.
Can I just add a tiny little bit? So sorry, I was just saying to Rosella, I'm going to have to run off in a little while. So essentially, part of shielding, and probably the most important thing about shielding, is please don't use public transport. Public transport is one of the unhealthiest spaces there is. So someone sits in a chair on a bus, coughs all over the area, gets up, leaves the bus. You go and sit in that space 2 hours later, the viruses they've coughed around will still be present. So please avoid public transport. If you need to get anywhere, please try and use public transport, taxis, or walk. So when you're coming into hospital, as part of protecting you, as part of shielding, we're providing hospital transport. So if you have an essential journey into the hospital, we will provide transport for you to get here. And this is part of the reason why it's useful to talk to us, because we'll give you the number for transport and warn transport you're going to call them. They will provide a single individual car for you, car or ambulance, which you will not share with anyone other than your driver. And that's all part and parcel of the shielding process. I'm really sorry, I'm running away now.
Okay, yeah.
That's really helpful to know.
Okay, so I think that literally answers the question about transport to the hospital during these times. Ambulance or hospital transport paid for presumably by guys or NHS, get the patients in safely and get them back home safely. In the absence of that, I wouldn't really recommend anybody is risking their lives to do anything different. Yeah.
And I think it's important to say that it would just be you. It's not your family can't come with you, which is maybe different to before. That visitors still aren't allowed, are they?
Not to the best of my knowledge. Visitors are still not being allowed. So, people just need to be sensible, and on the whole, they have been extremely good. Hence, we haven't really seen major problems with our sickle patients across the whole country. In fact, from what I understand, so that is really, really, really good to know. I was listening to some news last week, and Homerton apparently they have something like 70% drop in admissions within the sickle population. I'm like, wow. And that's just because people have been so good shielding. So I suspect that if we look at the numbers for our trials also, there's a good chance it's going to be pretty, that high too, in terms of the drop in admissions and people coming in generally. So, the advice is stay off public transport. It doesn't even matter whether there's a pot of money somewhere for you to pay for it. It's just not safe. So if it is not important, essential, where guys would organize the transport through our hospital transport system, then I would say then it can't be that important. Then just stay at home, really.
I think with that in mind, around a few more questions about hospital, I think we might have Heidi, one of the specialist sickle cell nurses, with us. Is that right, Heidi?
Hear me? Hi.
Hi, Heidi.
Hi.
Thanks for joining us, Heidi. We know that you also don't have a camera up, so listeners will be able to hear Heidi's voice. Heidi, I wonder if you could share with us a bit of information about the use of the sickle cell nurses support line. It's been mentioned by Daniel, it's been mentioned by Rachel, and myself as well, in terms of ways that people can get in contact for further information. Could you share the number and the aim of the line for us, please?
Yes, of course. So during this COVID situation, a lot of people are very hesitant to come to hospital, and I could understand that. But we've always said that obviously with the helpline, we will be able to help over the phone and see what the symptoms are, if they are in any pain at home, or if we can maximize their medication at home, or we can manage them at home. So we've always so the helpline is sort of an advice line for most of our patients who are obviously reluctant to come to hospital. But we've also advised in this regard that if they're not able to manage this at home, then they have to come to hospital. So there's a couple of patients. There's a lot of patients who actually we successfully help manage their sickle crisis at home. And they've been were successfully avoiding coming to hospital and not being more exposed to obviously COVID. But as well as that, we always say with our advice that we don't, of course we wanted you to stay away from hospital, but at the same time we don't necessarily want you sitting at home getting sicker and not being seen by anybody. So if they need to come to hospital and seek seek their get the doctors to see them, then they have to come to hospital.
That's really helpful to know. Thanks very much, Heidi. Is there anything else that you'd like to share generally about patients coming into hospital?
Yeah, I mean, as I said, some of the patients are quite anxious and quite hesitant in coming to hospital. But as Rachel earlier has mentioned, there are two areas in the hospital where people are being seen. One of them is if you have the symptoms, then you go to that part of the hospital. And if you don't have the symptoms, you go to another part of the hospital where you're not exposed to other patients who have symptoms like cough or fever and things like that. And also, if you have appointments in hospital, it's still like for some of our patients who are on hydroxycarbamide that needs blood monitoring. Sometimes we recommend if they wanted to go to their GP to have their bloods done, we can arrange that for them. Or if they have to come to hospital, we always say to them to avoid public transport. And what we do is we advise transport of people coming into hospital. Sometimes they would ask us to say to them to email transport and get them to bring the patient to the hospital, so they avoid public transport. Like Rachel has mentioned earlier, I suppose she's mentioned that earlier.
It feels like when everybody's talking, it's the safety of the people that we support is really paramount in the decisions and processes that are being taken. So it's really helpful to know from all sides that there's lots of support available. But understandably, there's a lot of fears and worries and anxieties, and we don't know, all of us, how long this is going to be going on for. So there's, I'm sure, lots of questions that people have about how long this is going to be like this and how long the hospital will have changed in this way. And unfortunately, those aren't questions that we're able to answer at this stage. But hopefully from this series today, you're learning and understanding that there is support available, both in terms of financially, thinking about welfare support and benefits, thinking about housing, or at least understanding housing and questions around it, and then also around medication care and coming into hospital. And the team here at Guys is really behind you in terms of support and care, and we want to be able to give a really holistic service. So both thinking about your physical well-being, thinking about your social needs, and of course from us in the psychology department, thinking about your psychological needs and your emotional well-being too. Not only because we know that sickle cell is both a condition that affects your body physically, but it also has effects on how you're feeling, your quality of life, your experience. So hopefully continue to come together and work hard for you to make sure that you're living the best quality life possible, even though this COVID time we know is really hard. Are there any other comments around welfare benefits or support before we move on to our final section, which is thinking a little bit about your emotional well-being?
No, I don't think so. Sounds really like a really good overview.
Yeah, I think the only thing I want to say is that people just need to make contact with us before, you know, they put pen to paper with these things. Yes, I appreciate that not everybody necessarily needs the hand-holding type help where they're perfectly comfortable to do these things, and that's fine. But for anyone who is just not sure, it's best to just double check. And anyone who is already on DLA and almost certainly will be transitioned over to PRP, it will not be an automatic thing. We want to try and encourage them to reach out, you know, at the very least, speak to us. And even if you still are capable of filling in the form, you might definitely learn a thing or two just by having that conversation with us. So, you know, yeah, that's all I want to say on that as well. Yeah.
Thanks, Daniel.
Cheers.
Emma, I wonder if you could share with us perhaps some of the themes that have come up generally with some of the people that you might have been working with, and as well for you, Sickle, if there are any kind of general themes that you think might be challenging for people at the moment in terms of their emotional well-being, and if we have an overview of any quick tips that we might be able to give in the last few minutes.
So thanks, Rosella. I run the Sickle Cell support group normally on a Tuesday evening, but we've gone virtual recently. So on Thursdays from 1 till 1:40 for people with sickle cell from Guy's and St Thomas's, we are running a Zoom call. So feel free to email us if you'd like the invite. We've got lots of different people talking about different things. I think quite a lot of these topics come up and people have some great ideas. So people know about different places to get prescriptions or finding out about the best place to so some people have been overwhelmed with the amount of food from the government support boxes, and they've told me about this place called Olio, O-L-I-O, which you can get an app and you can share your food for free, and they feel like that's a way of them being able to give back when they feel like they're shielding, which can feel quite tricky. Some people have really enjoyed the rest from this time. Some people have felt really lonely and isolated. So I think it's been a really individual experience, especially during the pandemic. And everyone's valid and all the emotions are, able to be explored and thought about, and some of the positives of it and some of the more challenging things.
Yeah, I think for me, when speaking to patients, I think lots of the things that Emma mentioned have been brought up. I think lots of people have been finding it difficult to create a balance of home life and working from home, and ways to kind of create a routine to overcome that. I think lots of people have been enjoying the parcels of food that they've been receiving. Some people don't find everything in the box helpful and weren't aware that they could have food delivered by their local supermarket. So that's something I definitely advise, because vulnerable adults are able to contact them and get a delivery slot. And I think in general it's just been a really strange and difficult time for some people, but some people have coped really well. And I think, as Emma said, it's just a really individual experience for everyone.
And I think one thing I forgot to say is that sleep is one of the big things that most people I've spoken to have had affected at some point. So either their routine's been thrown out a bit and they're finding it a bit more tricky, or they're sleeping more or less than they used to before. And that's something we're thinking about doing another one of these webinars on, just to give some hints and tips about what might be helpful. But I think the main thing is taking each day as it comes and doing what you can in your control. So whether that's just choosing to make a favourite dinner when you're feeling a bit rubbish, or whether it's calling a friend who you know is going to brighten your day, those little things can really shift the day around, I think.
I guess
Thanks so much to everyone.
Oh, I was going to briefly mention, sorry, that the team have created the booklet that we can send out to everyone that has lots of kind of tips and resources that they can access as well.
Yes, great point. As part of your email letters that will be going out, attached to that is a patient pack called, what's it called?
Coping with
Coping in
COVID.
COVID Times.
Yeah.
It has some resources in there, some kind of worksheets. I know that a lot of people have talked about being in pain and needing a bit of distraction. Some people being quite bored and quite isolated from people. So please do check your emails to see if you'd like the patient to use the patient pack, or if you'd like us to send one out to you via post, please get in contact with us via the emails. I'd like to say a really huge thank you to everyone for joining us on the first of hopefully what will be quite a few Haematology Health Psychology online webinar talks. Thank you so much to you, Daniel, for joining us today, and I'm sure that we'll be calling on your expertise again in the future to help support us in the work and help support us and the patients very much with the work that you do. So thanks so much to you for joining us, and to
thank you very much.
Thank you.
And to Rachel as well.
Yeah, thank you.
Thank you. It's been a pleasure.
Thanks.
Bye everyone.
Bye.
Bye.
Take care.